So today we're going to be providing a brief review of trial designs, focusing on the differences between experimental studies and observational studies. Importantly, we'll discuss how this informs our understanding of clinical efficacy compared to effectiveness and how it impacts on cost effectiveness and decision making. Many of us will recognize the level of evidence hierarchy, these pyramids that are published. There's actually quite a number of these which have been modified and adapted over time. And often research asks different questions in different populations, and the types or the level of evidence has had to be modified. So, for example, pyramids exist for evidence of treatment, prognosis, or diagnosis. So, this is the pyramid developed by the Centre for Evidence-Based Medicine for treatment. And the levels are there to inform which studies may offer the highest level of evidence, reduced probability of bias, and thus provide sound evidence-based guidelines. At the bottom, you can see those studies that lack a trial design. So it may be either based on expert opinion or the collection of a number of cases. We then move upwards towards studies that are more observational in nature. So these studies that observe participants undergoing treatment or therapy up to the highest levels of evidence, the randomized controlled trial or the RCT and meta-analyses of RCTs. But I think it's really important to note that whilst RCTs are often placed at the top of the pyramid, that how they've been conducted and the results of those trials really need to be carefully interpreted, and how it impacts on the assumptions for cost effectiveness of therapies or medications is something I'll be coming on to. So really simply put, a randomized controlled trial is a prospective study that recruits eligible participants and then randomly allocates them to two or more treatment arms. So treatment A, treatment B, C, or D. And the randomization is there to ensure both arms are equal, and it aims to reduce differences between the two groups, which might introduce bias into the analysis. So there's a number of statistical techniques that can be used as well, such as minimization, to try and ensure that there's balance between those arms. Patients are then followed up over a period of time, and then the outcome is compared. At the time of recruitment, there's no knowledge of which group the patient will be allocated to, so termed concealment. And it's often ensured by using a computer to generate a randomization system that randomizes patients to A or B. So treatment may be blinded so that neither researcher or the patient knows what they're receiving, but they can be unblinded as well. And it's a real controlled environment so that the study is conducted in patients who fulfill strict eligibility criteria. And the way that we analyze this trial, the statistical analysis plan, is often predefined. So this is a quote by a Scottish epidemiologist and really one of the pioneers of evidence-based medicine. He was one of the strongest advocates for the use of the RCT, but like really many great thinkers, knew its limitations when he said between measurements based on RCTs and benefit actually in the community, there is a gulf which has been much underestimated. So whilst the RCT is one of the most reliable methods of determining treatment effects in theory, an RCT's main question is, does the treatment work under ideal circumstances? So under this controlled environment. The population selected meets really strict eligibility criteria, such as their age, any lack of serious comorbidities, serious illnesses, which might not reflect how we use these treatments in real life. So RCTs of a treatment are the example really of an efficacy trial that determines whether an intervention produces the expected result under ideal circumstances. They determine if the treatment works in a controlled and highly selected patient population who fulfill eligibility criteria. So they provide high quality evidence, but they may not be overall reflective of what happens in the real world when these treatments are used in the clinic. So I'm going to consider an extreme example using my field of research, which is rheumatoid arthritis. Let's say we wanted to test whether drug X improved disease control. So we were very good with this study, and we recruited 500 patients with active rheumatoid arthritis and gave half of them drug X and the other half placebo. We wanted them to be naive to previous advanced therapies, so previous biologics, so we can see if the drug works in that population. And we wanted to exclude those with comorbidities because we were concerned it might impact on adverse events. And we also know that those with more comorbidities may do less well on treatment. So already we've removed those patients who do not fulfill the eligibility criteria. And there's a population that were invited to take part in the trial, but didn't choose to take part in the trial. So there may be some bias in that as well. We've then randomized them, ensuring equal arms. And when we compare outcomes, we see that in this study, hypothetical study, that drug X has worked in the majority of patients. So in the green that's shown there. So whilst this is it's a real extreme example, it demonstrates what we need to understand in RCTs, that these RCTs can be a controlled environment. The population may be healthier. And in this study, we've compared it not to the standard treatment in rheumatoid arthritis, but to placebo, which we don't give in the clinic. So there's no head-to-head trial for us to know definitively how this drug compares to our standard therapy we give for rheumatoid arthritis. So it wouldn't be applicable or transferable to what we would see or may see in the real world. So the effect size that we have from this study, so how well drug X has improved disease control over placebo, is a measure of how efficacious the drug is, but not of how effective the drug is in the real world. So that shows to me that whilst we place RCTs at the top of the pyramid, the study should be critiqued to understand their context, so how they might fit when this treatment moves forward to the real world. And there really is a number of factors to take into account when reviewing RCTs that affects their external validity, so how transferable it is to the real world. And as we'll see later, the assumptions we make for how cost-effective a treatment may be. External validity is the extent to which the results of a study can be generalized to the general population, the setting, such as a country or a healthcare setting, which can vary a lot, and time. So, for example, how long a drug could be expected to be effective for. External validity is affected by the use of artificial settings, so these controlled environments, such as a tight eligibility criteria for entry into a study. Internal validity is the degree the study establishes a cause-effect relationship. So if I give this treatment, will this patient get better? That's the cause and the effect. And it focuses on the reduction of bias, which is brought through by randomization and is affected by selection bias and also how well we measure outcomes, so measurement bias as well. If we think about what could affect external validity, it can include the trial setting, so how the system could deliver drug X treatment in the real world, or which sites have been selected. So if in a trial all the sites in the study are highly specialized sites with lots of additional resources, that treatment, that intervention may not work as well when used outside of these settings. Patient selection is a real big driver of this external validity. So studies that have a highly selected eligibility criteria may restrict the results to just that population. So just those young patients or those ones who don't have additional illnesses or comorbidities. So the use of classification criteria, for example, is quite common for entry into a study. And on the one side, whilst it's really helpful to reduce the inclusion of patients who do not have the disease, so making it a entry requirement for patients to be classified as having a disease. In the real world, patients may be diagnosed based on clinical criteria, based on their symptoms and signs, as opposed to do they fulfill all the classification criteria. So how this is shown in practice is a good example of this study. It was a while ago, so from 1992. So they looked at 214 drug trials in heart attack, so patients presenting with acute myocardial infarction. And it showed that over half of these studies excluded patients over 75 years of age. So those more than half of those studies haven't been able to give us any evidence for whether these treatments should be used in those who are over 75. And it's those patients who are over 75 who may be at increased risk of side effects, which is an important outcome to measure. Delivery of trials, so how we perform the trials in hospitals, can also inadvertently affect recruitment and cause selection bias. So, for example, if we don't translate material, if we don't have availability of interpreters, or we recruit white-only patients or use white-only images in advertising material, it might skew those patients who feel invited to take part in the trials, which may affect the results. So from my area in rheumatoid arthritis, we see that individuals living with rheumatoid arthritis in racial and ethnic minority groups consistently experience lower remission rates compared to Caucasians. So in 2019, so really very recent, data from a systematic review of demographic characteristics of participants in RCTs with rheumatoid arthritis showed that the enrollment of racially minoritized people is significantly lower than the general population. So we know that patients with rheumatoid arthritis in racial and ethnic minority groups have lower remission rates. But despite that, our trials from this study in 2019 are not recruiting those patients who are most at need of effective treatments. And in some studies, ethnicity is not reported at all, so we don't even find out if selection bias has occurred. Finally, the intervention itself can affect external validity. So protocols that deviate from usual clinical practice, such as exclusion of additional therapies, such as painkillers or other analgesics that would be used in real life, could affect how effective that intervention might be. And we often see that there is a higher adherence to the interventions, such as exercise therapy, in clinical trials compared to the real world. Trials may also have a short follow-up time, which may miss adverse events or outcome measures that we might see in the real world. So those adverse events that may take a lot longer to develop, if you have a short follow-up time, we may miss those in the study. And then also some RCTs may use an outcome measure that we wouldn't use in the real world. So for example, looking at a blood test such as cholesterol instead of how effective a drug is to reduce the risk of a heart attack. So that's at the top of our pyramid, so the randomized control trial. So if we look further down in the evidence pyramid, we come to those non-experimental observational studies. These studies may look at effectiveness to answer whether the treatment works under real-world circumstances. So they measure the degree of effect under real-world clinical settings and are based on conditions of routine clinical practice and use of outcomes that are essential for clinical decisions, such as does this treatment reduce heart attacks as opposed to does it reduce your cholesterol? There really are, though, still with these observational studies, variables that can modify the effect, such as patient preference or the doctor-patient relationship that can modify how strong the effectiveness is of an intervention. So I view that these studies help to complement our knowledge of the effectiveness of the intervention in the real world. Observational studies can be cross-sectional, looking at a single time point, or longitudinal to see what happens over time. Retrospective studies look at data on past events such as healthcare records, which has the advantage that we do not need to wait for data collection, but that can be prone to recall bias. Prospective studies recruit and follow up patients for data collection, often until a predefined endpoint, such as did someone develop an infection, or they may follow people up until a cutoff point of 5-10 years, for example.
James, you have 5 minutes.
Okay, thanks so much. So observational studies are not randomized, so they can be prone to confounding. And so an example of a confounder is confounding by indication. So if we wish to explore the effect of an advanced anti-rheumatic drug compared to a conventional drug in rheumatoid arthritis, patients with higher disease activity may be offered more targeted therapy. But those are already higher risk of infection due to having a higher disease activity, comorbidities, and also prior treatment. So we may see that there's confounding. So there's a number of ways that we deal with this. This could either be by adjustment for those confounders, or we may propensity score match, which matches treated cohorts for covariates to give them a score, a balanced score, to reflect the likelihood of them receiving the treatment. So observational studies can be much more practical to run. They can be more economical to run, and they can sometimes provide preliminary evidence of an effect that can then justify a randomized controlled trial. Because of the bias in observational studies, we say that they give us association of effect and but not causation, so not cause and effect. And we often suffer from missing data with observational studies. So how does this affect any health economic analysis? Well, there's limited resources, so we often need to prioritize which treatments will be funded. So a health technology assessment helps to prioritize resources and inform decision makers on the technology and the strengths and weaknesses. Trial data used really is paramount for that evidence, and often for a new technology, evidence of efficacy from RCTs is all that's available. But this may not translate into significant cost-effective reductions in clinical endpoints, so such as a drug that reduces blood pressure, as opposed to a drug that in clinical scenario results in a reduced rates of stroke or heart attacks. And effectiveness data can therefore provide information on actual health resources. So to actually deliver this treatment in the real world, which again helps to complement our understanding and bridge this evidence gap. So as a patient, we often ask, well, which treatment is better for me? And I think that's a really difficult question to answer due to the lack of trials directly comparing two different treatments. We may be tempted to use data from observational studies, but often these are not powered or designed for a direct comparison and are prone to bias and confounding. and papers of a single intervention versus placebo are not directly comparable due to differences in study design, washout periods, and patient population. So I'm going to skip through this real world example. Oh, actually, no, I do have time. So here's a real world example by Zink et al. Of chronic rheumatoid arthritis. So chronic inflammatory autoimmune disease. TNF inhibitors are advanced therapies that help to control the disease. And they looked at data from the German Biologics Register, which is an observational study of biologic therapy called the Rabbit study. And they looked at how many patients treated in their cohort with a TNF inhibitor, so in this real world observational study, would have been eligible for those major clinical trials that led to the drugs being approved. Really remarkable. So only 21 to 33% would have been eligible for those first trials. And they saw that response rates were lower in patients ineligible for the trials who had higher levels of comorbidity and lower functional status. I think that's really powerful. So these are my conclusions. So trial design affects the assumptions made thereafter on cost effectiveness of interventions and external validity, and when assessing the health economics of an intervention. It's really important to critique the evidence and take a mixed approach where available. So having not just the RCTs, but the observational studies, which give more real world evidence. And there really is a significant gaps in inclusive research. But now that we have a better understanding of this and its impact, I think and I hope that we're improving in making studies much more inclusive. Finally, I'd like to highlight, as Denny has said, our Inotta's short-term scientific missions. So these are fantastic grants available to facilitate scientists going to another institution in another country. So if you are interested or you would like to consider coming to my hometown, Manchester, please scan the QR code or do get in touch. Thanks so much.
Thank
Fantastic.
you. Thank you
Thank
very
you,
much,
James.
James, for this excellent presentation. Okay, now please turn on your cameras and microphones. Okay, and
Yeah, you can ask your question directly to James. We have a few minutes for
yeah,
question and answer. I have just to start with a question on the clinical trial design. Do you involve patients in the design of your clinical trial?
So this is becoming more and more frequent to involve patients in the design because, and I do in mine, we have patient partners to assist us in the design of our trials because it's patients who are real experts in their disease, be living with that. And if they tell us that actually, if a researcher came to me and said, "Would you want to take part in this study?" and I wouldn't, that's really important information to know because that would absolutely fail the trial from working.
Any other question from the audience?
I don't
Celia,
see.
I think Celia is rising.
Okay.
You,
Do you have any questions? Okay.
I do. Thank you. Thank you for this very useful overview and reminders, James. I just wondered, do you have any experience when you thought that over-interpretation or misinterpretation of clinical trials affected clinical practice in your field?
So I think the best examples are the strict eligibility criteria for the initial studies, such as in TNF inhibitors, that means that patients had lower rates of comorbidities, um, which which may have meant that we saw lower risks of adverse events. Um, and you know, I understand that when when you have your technology that you've invested heavily in, that when you start with the clinical trials, you start with a small, strict criteria that might be eligible. And then as the drug gets used more and more, you look for that more real world clinical evidence, the post-marketing studies. But I think it is really common that the initial studies with the technology that's been heavily invested in, they have strict eligibility criteria, and that means that when you translate it to the real world, you might not see the same outcomes as were expected.
Thank you.
Thank you very
Well,
much.
I don't think we have more, or maybe one question on the chat. Okay, so should we bring the computer? Okay, so it's something apart from that webinar.
Yes, yes.
Can we maybe, unless there is other question, can we adjourn by presenting the next webinar? Pavel, do you want to present the next webinar next month?
Yeah, sure, of course. Next webinar will be held on 9th of April this year from 5 p.m. to 5:30 p.m. And the speaker will be Meghna Yanni. She's a senior clinical lecturer at the Center for Epidemiology versus Arthritis, Center of Musculoskeletal Research at the University of Manchester. And the title of the webinar will be Systematic Review and Meta-Analysis. So please register for the next webinar. And thank you for attending and participating, and see you at the next webinar next month.
Thank you very much. Bye-bye.
Thank you. Bye.
Thanks, bye.